I'm here to present to you the effect of TX new surge on linkage to HIV care in a decentralized healthcare system in Jinja district, Uganda. The summary of the presentation is basically, I will give the background of the study, some operational definitions, the study objectives, the methodology, study results and discussion, recommendations, references, and then the conclusion. What is the problem or the background about the study? The United Nations AIDS Organization implements targets that are related to achieving HIV epidemic control that we term as the 90-90-90 targets, aimed at achieving 90% of all HIV positives being identified from the community. Out of the identified HIV positives, it also aims at having 90% of them put on treatment, and also those who have been put on treatment, 90% of them doing well on treatment, which we call viral load suppression by 2020. These targets give us a very good strategic direction to end AIDS by 2030. In Uganda, the Ministry of Health adopted the guidelines of World Health Organization of HIV test and treat policy in 2015, which was aimed at fitting into the UNAIDS 90-90 targets. Uganda rolled out the policy on test and treat in 2017 using the guidelines termed as or named as the 2016 Consolidated HIV Prevention, Care and Treatment Guidelines. And as a district under the country of Uganda, Jinja District started implementing the test and treat policy in August 2017. At that time of August 2017, the linkage to treatment after diagnosis of the HIV individual was only at 62%, and this was below the 90% target as per WHO, UNAIDS, and Uganda as a country. The district got support from URC Rights EC as an implementing partner to support what we called TX New Surge in an effort to achieve the second 90 of linkage to treatment under the test and treat policy in only 13 selected health facilities of Jinja, Kakira, Buwenge hospitals, Budondo, Bugembe, Buwenge, Mpumude, and Walukwa Health Center 4s, and Kakira, Kakaire, and Jinja Central Health Center 3s, and then 2 centers of excellence, what we call TASO and Family Hope HIV/AIDS clinics in the district. The study health facilities were supported with both financial and material resources to ensure that the first 90 of identification of HIV positives is achieved, and also linkage to care and treatment is achieved in the district. There are a number of modalities that were used. The number of modalities that were used to ensure that we do identify the HIV positives. And some of these modalities included community-targeted outreaches for testing HIV, the testing of HIV key and priority populations, index grant testing, assisted pattern notification, and testing, facilitated testing at all entry points, and programs like prevention of mother-to-child transmission of HIV, circumcision, nutrition, among others. These were all efforts to ensure that we do identify as many HIV positives in the community as possible. The district conducted weekly support supervision to the health facilities that were implementing the strategies. And also the health facilities were having weekly meetings to review their performance against set targets for them to be able to achieve the desired number of HIV positives that have been identified, put on treatment, and also improving their main methods of working. Operational definitions that I wanted to highlight. One was about the TX new. It is a new term, but in this study, It meant a newly diagnosed HIV positive, HIV treatment naive patient who is cancelled and initiated on HIV treatment in not more than 2 weeks of HIV diagnosis. When it comes to the surge, the TX new surge, these were just accelerated efforts to identify and initiate all HIV positives on lifelong HIV treatment in the district. What were the objectives of the study? This study was an evaluation of an implementation of the TX new surge. So basically, this study had only two objectives. One, we wanted to determine if the TX new surge had any effect on the linkage to care from 62 maybe to a better position, and also wanted to suggest ways in which linkage to HIV care can be sustained to achieve the second 90 target of the units. I want to note that 13 HIV high volume health facilities in Jinja, as noted before, that had implemented the TX new were studied, and these study health facilities were, we had 2 private hospitals, 1 public hospital, 8 lower level public health facilities, and the 2 centers of excellence, Tasso and Family Hope Center, Jinja. Data was collected from the district, from the health facilities, for a period of 9 months. That is between October 2017 and June 2018. And we used the usual data collection tools of HIV counseling and testing register, the pre-HIV treatment register, and the HIV treatment register. That's where the data was collected. Data on number of individuals tested, those identified as positive, those put on ART treatment, was all collected using an abstraction tool. What were the results? In this table here, you note that the health facilities performed in terms of linkage at different levels. One, we can highly note that Kakira Workers Hospital, that identified 242 clients, only managed to link 37 clients, having a linkage of only 15%. Whereas Jinja Regional Referral Hospital, that identified 740, linked up to a tune of 79%. Buenge Hospital, which is a private, also linked to up to 76%. Budondo Health Center 4 linked up to 57%. Bugembe Health Center 4 linked up to 60%. Walukuba linked up to 172%, as it will be explained. Buenge Health Center 4 linked only 49%. Mpumude linked only 56%. Jinja Central linked 46%. Kakira Health Center 3 linked only 86%. That is Kakaiden Kakira linked 48%. Tasso Jinja, a Center of Excellence, linked up to 89%, but also it identified a very big number, 1,071 individuals as positives. And Family Hope, that identified 382, managed to link 429 HIV positives identified. On the point of discussion, I want to note that in total, all the facilities tested 132,975 individuals that were tested by all the 13 health facilities, out of which 3,991 were identified as HIV positive. On average, the positivity that was calculated, it was 3%, but the linkage, the average linkage of all the 13 health facilities was 78% linkage to care. The same results showed that in rural areas, the positivity was 1%, as compared to the urban areas that had more than 3%. But also, this was consistent with the Uganda Population HIV Impact Assessment Survey that was conducted, that indicated that urban areas are more affected by HIV than the rural areas. Results continue. The hospitals, the 3 hospitals, we had 2 private hospitals and 1 public hospital. I want to note that the hospitals had limited linkage to care, ranging from 15% by Kakira Workers Hospital to 79% by Jinja Regional Referral Hospital, which is a public health facility. And just like the linkage was almost uniform for other health facilities. But Jinja Regional Referral Hospital, which is a public hospital, had a better linkage than the two private hospitals of Kakira Workers Hospital and Bwenge Hospital. There was a unique achievement of 172% achievement at Walukuba Health Center 4 compared to all the other health facilities. This was attributed to the poor linkage before the start of the TX new surge at the facility, as other clients who had been already identified but not put on treatment came in to seek treatment at this facility. Otherwise, the other health center 4's linkage ranged from 49 to 60% linkage. The linkage at Health Center 3's was not different from the hospitals and the Health Center 4's, as it also ranged from 48 to 86%. The centers of excellence, just to mention, TASO, Ginger Clinic, HIV Clinic, and Family Hope, HIV Clinic, they had a better linkage to a tune of 89% and 112%, respectively. Recommendations. It has to be noted that the implementation of the TX new surge or the application of accelerated efforts to look for HIV positives and put them on treatment improves linkage to HIV care and treatment. However, there is need for addressing the challenges of counseling of service providers to meet the needs of those who are tested positive. You realize that the public health facilities had a poor linkage compared to the centers of excellence, TASO and the Family Hope, that have very good skills in HIV counseling. There is also need for the study to relate the factors of patients to treatment. What prevents the HIV positives to be put on treatment? Yet, in the TX new surge, there was need for provision. There was provision of the logistics and the supplies, finances that were needed during the period of implementation. I just put a few references, about 4 of them, as noted. So in conclusion, I want to conclude, 1, that linkage to HIV care and treatment was better at the centers of excellence. Therefore, they are visible for good investment. Then the public hospitals have better linkage compared to the private hospitals in terms of linkage to HIV care. There is also no much difference in linkage between the hospitals and the health center 4's and the health center 3's. The linkage is only more strong in the centers of excellence, the private centers of excellence. Lastly, the TX new surge improved the linkage of HIV positives from 62% at the time of implementation to 78% in the 9 months of implementation. However, the 78% achieved during the TX new surge is not the 90% achievement that was aimed at. So this calls for more interventions beyond only implementing TX new efforts. Thank you for listening.
We can go for the next session, Q&A. So, dear participants, please raise the questions in the Q&A session. You can share.
Okay, thank you very much for the question. I want to note that during the implementation of the TX new surge, health facilities had quality improvement projects that were related and aimed at determining the improvement in terms of achieving the targets for HIV testing and then linkage to healthcare. So there was a lot of relation in terms of the projects being implemented and also looking at how are they achieving the targets, because each facility was given a number of targets for HIV identification and also putting how many have been put on treatment. So against all efforts that were put in place to ensure that those identified are put on treatment, including the supervision, the meetings, the quality improvement journals that were used, there was an improvement in the kind of identification and also in the kind of initiation to treatment. So definitely I contributed this because of the effort that were on the ground I contributed this improvement in linkage to care to the accelerated efforts of TX New Surge in the region.
So you have the next question. What are the challenges experienced with TX search that might have limited meeting the 90% objective?
Thank you very much. The limitations could have been related to the high targets that were imposed on health facilities to identify and also put on treatment given the human resource available, because as much as the health facilities were given the number of people to identify as positive and also put on treatment, it was also mandatory that they needed to increase on the number of staff, which did not happen. So the few staff that also had limited skills in counseling affected the linkage too. There was also accelerated intervention in the community, including HIV testing and giving results in the community, and also providing HIV treatment in the community as a policy of test and treat. But at community level, provision of ARVs at community level, there is a lot of stigma. Even just the period you take counseling somebody who is HIV positive is more longer than the person who is HIV negative. So just the suspicion that somebody will be cancelled for a longer time, or it makes him off to say, I will not go for the treatment, I will come to the facility, and yet they ended up not coming up to the facility. Even when they were being followed up at community level, they had changed their names, so it was very hard for you to identify these people at community level. So some of these challenges affected the health workers to provide the care and treatment. Some health facilities had some centers of prevalence. That is why you saw that one of the centers of excellence, Family Hope, had a bigger linkage to care, simply because some health facilities are not trusted by some of the communities that they serve. So a client can be identified by health facility A, and he does not come back to health facility A, but he goes to another health facility to see if he will get the same results, and also to see if he will be started on treatment. So basically, stigma is the major challenge. The counseling skills of the health workers was a major challenge, and also the health facility workers, I think, had little capacity in terms of human resource to be able to achieve the 90%.
Okay, fine, Mr. John, your answers are good.
And linkage to care.
Our next session is polling. We are moving to the polling session. Participants, please poll for Mr. John. So we are ending the polling session here. Thank you, Mr. John, for the participation.